Okay, everybody, we're back for part 2 of chapter 9, and we're talking about community-acquired pneumonia. And our three culprits that can cause this pneumonia are your Streptococcus pneumoniae, your Moraxilla catarrhalis, the H flu, Legionella pneumophilia, sorry about that, and Staph aureus. You also can have a viral pneumonia. You can have, you've heard of the walking pneumonia, which is typically caused by the mycoplasma. You can have chlamydia pneumonia, anaerobic pneumonia, nosocomial bacterial pneumonias, and then a CMV pneumonia caused by pneumocystitis jirovecili pneumonia. Goodness. When your patient presents and you're concerned about bacterial pneumonia, there's some key information that you need to get subjectively. You might see you're asking more about what's gone on, and you may see that the patient has had a sudden onset of fever, cough, some chest pain, and they may have some rusty colored sputum. Some atypical symptoms include a gradual onset with a dry hacking cough, fever, headaches, chills, malaise, chills, that's duplicate, etc. Those are not typical of a bacterial pneumonia. Objectively, you're going to note some abnormal lung findings such as crackles, dullness to the lung fields, diminished breath sounds. These patients are often acutely ill and complain of as we talked about, that chest pain, and often splint one side of the chest due to that pain. We've all heard the term nosocomial, and that is a term for something that originates in the hospital. And for something to be a nosocomial pneumonia, you have to have certain characteristics that are present, and those include fever, elevated white count, purulent sputum, and a pulmonary infiltrate that was found on chest x-ray that was not there on admission, and these findings must occur more than 48 hours after admission to the hospital to be considered suggestive of a nosocomial infection. Diagnostic tests can include the chest x-ray, and you're going to use this to assess whether it's bacterial or viral and rule out if there's a pleural effusion. It also is going to rule out if there's any cavitary lesions or pulmonary infiltrates. A CBC is beneficial to determine whether it's bacterial or viral. This test will also tell you if your patient needs to be hospitalized. There is not a clear-cut demarcation on the WBC that says this is bacterial or not bacterial, but the book will mention that a total WBC count of greater than 15,000 is suggestive of a bacterial infection. You may even note a lower white count known as leukopenia in severe infections and those individuals that have malnutrition and may be alcoholic. A sputum gram stain is important and can be used as a diagnostic tool if your patient is able to produce sputum. After you've diagnosed the patient with their pneumonia, now it's important to decide whether they need to go to the hospital or if they're okay, well enough, not as severe, and treatment can be maintained in the outpatient setting. There are several diagnostic tools that are available. They're going to be on your sheet of web resources. I'm going to include an article on how to use different assessment tools, and then links for one called the Curb 65, and it's a pneumonia scoring tool, and then some guidelines for treating community-acquired pneumonias. Also in the book on page 375, there's a section 9.3 that discusses the risk factors for mortality and any complications associated with community-acquired pneumonia. Be sure and look at those. Of course, age comes into play, coexisting illnesses, any abnormal physical findings, and abnormal lab findings. So review that on page 375. And then in the book, there's antibiotic guidelines for community-acquired pneumonia on page 376, but then also one of the links that I'm providing will give more detail and dosing information. So your patient has community-acquired pneumonia, and you are making your decisions on what antibiotics to choose. The preference is monotherapy by choosing either doxycycline or a quinolone. In the guidelines, when you look at those for outpatient treatment, it breaks it down very easily. If you have a patient that's been previously healthy with no risk for any drug-resistant strep pneumoniae infections or any use of antimicrobials in the last 3 months, then you're going to go single agent, as we talked about with antibiotic or a doxycycline. If they have comorbid conditions such as diabetes, chronic heart disease, lung, liver issues, alcoholism, malignancies, etc., then you're going to go with more of a respiratory fluoroquinolone and then add, or a beta-lactam plus a macrolide. So look at this community-acquired guidelines, and that will help you in making your decisions for antibiotics. Follow-up is important, that we check back with these individuals in 28 to 48 hours. An office visit in 1, 4, and 6 weeks, and like Dr. Brandstetter said, it's important to make sure that you're checking an x-ray to make sure that there's resolution. 50% of infiltrates have resolution in 2 weeks and 75% in 4 weeks. So it's important that these are done if symptoms have not improved, if the symptom is a spoker, but also to make sure, as we talked about yesterday, there's no underlying condition that is there that may be obscured or the pneumonia could have caused. Okay, let's go over a little bit briefly on tuberculosis. You may discover this in the office, but others will be involved in the patient's care if they are diagnosed with it. We all know that tuberculosis is caused by the Mycobacterium tuberculosis. One of the first things that is often seen is hemoptysis. It can have a slow onset. You can have anorexia, fatigue, weight loss, cough, and a purulent mucus and cold-like symptoms. You can also find gone complexes on the chest x-ray. And then there's also miliary TB, which is a disseminated infection. As Dr. Brandstetter mentioned yesterday, the Mycobacterium tuberculosis is an aerobic organism, and it's attracted to the apical segments of the upper lung lobes where there's high oxygen concentration, and that's where they like to settle in and get their feet dug in to cause issues. On page 381 in table 911, there are factors contributing to a decreased response to the tuberculin skin test. There is also, right above that, some screening recommendations and guidelines for TB screening. So I encourage you to be familiar with that. So diagnostic test would include your tuberculin skin test, and this is where you inject 0.1 milliliters intradermally to produce that wheal, and it's read anywhere from 48 to 72 hours after the injection occurs. When you go to interpret the skin test, what you're looking for is the diameter of induration, and it's typically divided into 3 categories: less than 5 millimeters, less than 10 millimeters, and less than 15 millimeter induration. And based on the table, it will just tell you more about. Okay, so let's talk a little bit about findings, and also don't forget that under the lecture tab there is another tab that calls Respiratory Guidelines, and underneath that there are guidelines by the American Thoracic Society, and in that there are up-to-date treatments and testing for TB. But we'll go with what the book has for right now. So for if your TB skin test is positive and your chest x-ray is negative, then you need to pursue treatment for your patient. If there's clinical suspicion, then it's important to get a chest x-ray and be able to look at the sputum for AFB. And sputum should be collected at 3 separate times on 3 different days and sent to the lab for AFB. Your chest x-ray, if for initial infection, may show some parenchymal infiltration with same-sided lymph node enlargement. If you're concerned that your patient may have TB, it's also important to educate them on who they are around and the exposures that they might have already given. Another form of TB is called hematogenous TB, and it has a miliary appearance, and that is like a little small seed type appearance that is scattered throughout. You may see that the patient has an abnormal chest x-ray that should be monitored, and if there's no change over 3 to 4 months, then that indicates a past infection or possibly some other disease. If there's persistent infiltrates in older persons, you should consider that they have tuberculosis. In the testing, as we've talked earlier, sputum smears, which are done by an AFB, and that's a detection test that is seen in 50 to 80% of pulmonary TB. It provides quick preliminary confirmation, and positives should then be sent on for culture, which usually takes anywhere from 3 to 6 weeks. So your patient has TB. What's our next step? Medications are recommended for all positive TB results. Treatment in immunocompetent patients with a negative smear should be started while waiting on the culture if there's clinical suspicion. On page 385 in the book, it talks about drugs commonly prescribed and what's used as first line and second line TB drugs. So treatment is based on what your diagnostic findings are. So you would have an individual that had a positive TB culture by sputum on treatment for 6 months minimum, and someone that was HIV positive for 9 months. Drug resistance is most common in HIV patients and immigrants. Because TB can be spread so easily and quickly, there is a program that's offered through the health departments called Directly Observed Therapy, DOT, and that is something that should be considered with all patients, and it's observation of patients as they take their medicines to assure that they are taking what is prescribed. Prior to starting TB medicines, it's important to do some monitoring. Several of these medicines can impact visual acuity and change perception of red and green colors, so doing those tests are important. It can also impact the uric acid levels that we monitor for gout, so having a baseline uric acid level is important. Follow up frequently to assess for anorexia, nausea, vomiting, fatigue, dark urine, icterus, rash, paresthesias of the hands or feet, or any abdominal tenderness is important, as these can be common side effects of these medications. Doing a periodic physical exam to assess for weight, temperature, and changes in symptoms. And then most important is to do a bacteriological exam of secretions. So if you're noticing that there is a fall in the number of the level of the AFB on a weekly or biweekly schedule, that's a good indication that there is effective treatment going on. When someone has TB, the monitoring that you will do will be monthly until negative, and most convert to negative after about 2 months of treatment. But if the patient stays positive after 3 months of treatment, it's important to reevaluate the plan, make sure that they're being consistent with taking their medicines, and refer to a pulmonologist. And then also, after treatment is completed, they must have a negative culture. Chest x-rays after completion of treatment as a baseline will be important for future monitoring. So for your individual that is TB positive, prevention is important. I encourage you to look at table 913 on page 387, 388, 389. It talks about groups for whom preventative TB therapy is recommended. I'm not going to go into detail on that, but review that, and for if you do have patients that have positive TB findings, and what's best for their family. Patient education is very important, and we talked earlier about the directly observed therapy. Important to consider that for all patients. Need to identify who close contacts are. Consider that the patient is infectious for 2 to 3 weeks after starting treatment. It's important that they practice good hygiene, appropriate ventilation, and avoid close contact with another individual. Having a fan in a window, blowing outward, sleeping in a separate room, discarding mucus in a plastic or paper bag are precautions that they need to be instructed on. All right, let's talk about lung cancer for just a moment. We know that these cancers arise from the cells in the respiratory tract, and there's four major histological types. There's squamous cell, small cell, large cell, and adenocarcinoma. Some subjective symptoms include cough, sputum production, coughing up blood, shortness of air, wheezing, chest pain, pleural effusion, and one thing that I would like to add onto this is weight loss. That is a subjective symptom that I've seen several patients come in with maybe one or two of these, but significant weight loss over the last several months. Some objective findings include wheezing that does not disappear after coughing, absent or decreased breath sounds, diminished resonance on percussion, decreased or increased tactile fremitus, clubbing, loss of weight as we talked about, anemia. So as you're working these patients up, it's important that you get some baseline labs, CBC, chemistries, coag studies, an EKG, baseline PFTs, chest x-ray, a CT of the chest with contrast, sputum cytology. They may need a flexible fiber optic bronchoscopy to get a sample. They also, depending on what is going on, may have a fine needle aspiration biopsy. This will be determined by either the pulmonologist or the oncologist for diagnostic measures. And with the new line of treatments that are out, your immunotherapy, having more of a tumor is, having more of a specimen is important because further testing, more detailed testing is needing to be completed to see if immunotherapy is something that the tumor would be receptive to, or if they need to go with systemic therapy. With most solid tumors, there is a staging process, and sometimes your patients are very eager to know what stage they are, but that is broken down into the following categories: a T&M category for the tumor and the characteristics that are seen with it, more information about the lymph node, if they were present, if they couldn't be assessed, if spread has gone to another area, and then metastasis, depending on how far the cancer has spread. Management of lung cancer can include a surgical resection, such as a pneumonectomy or a lobectomy, then also chemotherapy. It can also include radiation, and of course there's going to be follow-up. Okay, let's move on to sleep apnea. This is probably something you may see a lot in practice. And sleep apnea is defined as a pause in breathing for anywhere from 10 to 90 seconds. You can have central apneas, which are absent airflow or absent respiratory efforts, and these are typically seen with neurological diseases. And then you can have obstructive apneas that are seen where the soft palate and the tongue fall backward, obstructing the airway. And then there's mixed apneas. So some diagnostic tests that we would run on obstructive sleep apnea. There's some subjective tests, and I'll include links for these. For the Stanford Sleepiness Score and the Epworth Sleepiness Score, you can have your patient complete these while they're in the waiting room or prior to coming into the exam, into the appointment, if that is what the appointment is about. Then the definitive test is your overnight sleep test. There is also the multiple sleep latency test, and I'll provide a link to that, and that is your patient undergoes several short naps and how they feel and how they are assessed when they wake up. And it's also important to do an oral exam to see if there's any devices that for mild or moderate sleep apnea that can be used to help keep that tongue and the soft palate from falling backwards with sleep and help with the issue. Some medical management that you can share with your patient, some general measures. It's important to avoid alcohol, any sedatives or hypnotics, as those are going to alter how you sleep. Even weight loss can help with sleep apnea and change the dimensions of the neck and how the tongue and the soft palate fall back. Oxygen therapy and can be helpful, as well as even like the breathe right strips that go on your nose that help open up your nasal passages. Some specific measures may include position therapy, your CPAPs or your auto CPAPs, and then, as we talked about, your oral appliances. Only about 75% of patients that use CPAP after 1 year continue to use their machine. So it's important, if they're supposed to be on some type of machine, to ask when they come in to visit. Okay, smoking addictions, it's important to know how much they're smoking a year and calculate the pack per day. If you are not familiar with this, you can Google that online. But in essence, it's taking the number of cigarettes smoked per day, multiple over 20, which is what's in a carton of American cigarettes, times the number of years smoked to give you the number of pack years. So it's important to know that. It's important for patients also to be aware of all the chemicals and gases that cigarettes directly bring into the lungs. We know that nicotine can be a toxin that depresses the CNS, and that the CO2 in cigarette smoke can equal an automobile's exhaust fumes that come out of the car. On page 420, there's this table 9.25 that talks about diseases that can be associated with cigarette smoking, and so it's important to review those. We know lots of things, though, such as cardiovascular. They can have some arrhythmias. They can have peripheral vascular disease. Endocrine-wise, you can have patients that have Graves' disease or a goiter, infectious tuberculosis, lung infections. We know that cigarette smoking is associated with malignancies, so be sure and look at that table to see how vast smoking can touch many different body systems. It's important to talk with your patient about smoking cessation, and that is something that you can use as a billable code in your office visit if it's something you complete. There are several different programs, and I have a few that I will give you information on in that web document of resources. But the 5 A's: asking, advising, assessing, assisting, and arranging for what the patient might need. There's lots of programs out there. There's inpatient programs. There's a lot of resources online that I will include on that web document. There's hypnosis, aversion conditioning support groups, and then, of course, pharmacological approaches. And those include taking oral agents such as bupropion, Effexor, nicotine replacement, and that can be over the counter, such as patches, gums, lozenges, and then there's prescription nicotine replacements that are nasal sprays and inhalers. So let me check and see. I believe that we are at the end, but I'm going to also include on the list of web sources some information on e-cigarettes. A lot of folks think that if they're not smoking, e-cigarettes are okay. It wasn't until 2016 or 17 that the FDA started regulating e-cigarettes, and the trend is that younger adults are not smoking, but they're going to e-cigarettes, and there's also a large population of the LGBTQ community that is using e-cigarettes, so I'll offer you that. And then there's an article on educating younger adults with cigarette smoking and e-cig smoking. So that's the end of Chapter 9. We have Parts 1 and 2, and I appreciate your time. Thank you.